Welcome. This video trains advanced practice registered nurses to work up and treat UTIs in pregnancy. You will manage the full path: screen, test, interpret, prescribe, and follow up. We will move through 4 questions. How do you diagnose UTIs in pregnancy? How do you test? How do you read the tests? And how do you treat? The evidence the evidence base is from the 2023 ACOG Clinical Consensus, the 2019 Infectious Disease Society of American Guideline, and the United States Preventive Services Task Force. This video, of course, is for advanced practice clinicians. It is education, not medical advice, and it is not to replace your judgment or your institution's protocols. Always verify doses, allergies, and local resistance before you prescribe. There is no commercial support and no conflicts of interest, and off-label uses are named as they come up. Here are the 5 objectives. So by the end of this video, you will be able to differentiate asymptomatic bacteriuria, acute cystitis, and pyelonephritis using ACOG diagnostic criteria, select the correct urine test at the right point in prenatal care, and collect a valid specimen. Interpret colony counts, pyuria, leukocyte esterase, and nitrates, including their sensitivity, specificity, and negative predictive value. Prescribe first-line antibiotics by diagnosis and trimester, and name the agents to avoid. Manage pyelonephritis, recurrent UTI, suppression, and test of cure follow-up. So UTIs are pretty common in pregnancy, but they also drive real morbidity. Let's look at the numbers. So for asymptomatic bacteriuria shows up in 2 to 10% of pregnancies. Your cystitis and pyelonephritis each run about 1 to 2%. Pyelonephritis peaks in the second trimester and is one of the most common medical reasons pregnant patients get hospitalized. So the reason to screen and treat untreated bacteria: ACENs. Pyelonephritis brings preterm birth, anemia, sepsis, disseminated intravascular coagulation, and acute respiratory distress syndrome. One caveat for an advanced practice audience: routine screening has lowered pyelonephritis incidence, and the strength of the screening evidence is moderate, not strong. The USPSTF downgraded the recommendation from an A to a B in 2019 after 2 trials showed only a 2.2 to 2.4% pyelonephritis rate, even in untreated bacteriuria. So we're going to be going over 4 parts: your diagnosis, testing, interpretation, and treatment. Each part answers one clinical question you face at the bedside. All right, let's start with part 1, diagnosis. The single most common error is treating all 3 the same, but they're not the same. All right, let's define all 3. So asymptomatic bacteriuria, which is 100,000 CFUs or more and no symptoms. Don't rely on those dipsticks. A dipstick will miss it, so you screen with a culture. Acute cystitis, which has lower tract symptoms, plus a positive UA confirmed by culture at 100,000 CFUs, which remains the diagnostic threshold. Treating a single organism as low as 100 CFUs when symptoms are clear is an author-level suggestion, not a guideline threshold. Pyelonephritis Of course, fever at or above 38 degrees Celsius, plus urine findings with flank or CVA tenderness. That one is systemic, and it is the dangerous one. Let me explain the mechanism so the epidemiology makes more sense for you. So, progesterone dilates the ureters, the growing uterus compresses them, both cause urinary stasis and reflux. Stasis lets bacteria colonize and climb. That is why pyelonephritis peaks in the second trimester and why recurrence is common. 4 to 5% of pregnancies have recurrent UTIs, and up to a quarter of patients with a prior pyelonephritis episode recur before delivery without suppression. All right, let's move on to part 2, which is testing. So we're going to have 2 clinical situations, right? Your routine screening and your symptomatic patient, but both call for different testing. Screening versus symptomatic workup. Screening, 1 urine culture early in prenatal care. Don't rely on that dipstick. Dipsticks at each visit do miss asymptomatic bacteriuria. After a negative initial culture, the evidence does not tell us to repeat or not repeat. So use judgment and risk factors. For any symptomatic patient, send a UA and a culture together. Specimen quality does matter. A clean catch midstream sample needs to be processed promptly, and it also keeps you from chasing contaminants. If you have urine that is held more than 4 hours at room temperature, that can actually give misleading counts and should not be cultured. And if you did not know, contamination produces mixed flora and false positives. I do have one caveat. When you do order a UA and a culture, usually it is ordered UA with reflex. I don't order reflex. I go ahead and do UA separate and a urine culture separate. All right, let's move on to part 3, interpretation. This is where clinicians most often overtreat or undertreat. You need to know your numbers and what they mean. All right, let's go over how to read a test correctly and what each finding tells us. A colony count at 100,000 CFUs is significant bacteriuria with clear symptoms, but lower single organism counts, they still count. Leukocyte estrase and pyuria are sensitive up to 97%, so they help you rule out, but they are not specific, so a positive alone does not prove infection. Nitrites are the opposite, highly specific at 94 to 98%, but often absent because not every uropathogen reduces nitrate. Enterococcus, group B streptococcus, and staphylococcus sapropsyttacus do not reduce nitrate. So a negative nitrite does not clear a symptomatic patient. The useful combination if both nitrites and leukocyte estrates are negative, UTI is highly unlikely, with a negative predictive value of 78 to 98%. But in a symptomatic patient, you confirm with culture rather than excluding outright. One workflow point, the lab runs sensitivities automatically on significant isolates, so ordering the culture is enough. Targeted therapy follows the report with no separate add-on order needed. Before I move on to the next slide, because that one is a knowledge check, I want to read over the scenario. I want you to think about it, how you would what your next step would be. So, a 24-week patient has no urinary symptoms. Screening culture grows E. coli at 100,000 CVU. What is your next step? Go ahead and pause. All right, so here's the answer. So the answer is B, treat with a targeted 5 to 7 day antibiotic course based on sensitivities. Asymptomatic bacteriuria in pregnancy is treated unlike in non-pregnant adults. Target the antibiotic to the sensitivities 5 to 7 days. Ampicillin is wrong because E. coli is its resistance is high. Okay, part 4, which is treatment. Let's go ahead and match the drug to the diagnosis and to the trimester. All right, so for lower UTIs, first-line agents for asymptomatic bacteriuria and acute cystitis. I wanted to mention that for nitro, there is either monohydrate or macrocrystal, which is sold as Macrobid. The typical dose is 100 milligrams POBID, and the macrocrystal form is 50 to 100 milligrams 4 times daily. Nitrofurantoin is a strong first-line agent for cystitis and asymptomatic bacteriuria, but it does not treat pyelonephritis, and you need to avoid it at term and in glucose 6-phosphate dehydrogenase deficiency. Cephalexin is a safe beta-lactam across all trimesters. Amoxicillin clavulanate is acceptable when the culture confirms activity and it is distinct from amoxicillin or ampicillin alone. Fosfomycin is a single 3-gram dose useful for adherence. Of course, lower tract only. Be aware that most United States labs do not routinely test fosfomycin susceptibility. Trimethoprim sulfamethoxazole works, but has trimester timing rules on the next slide. Do not reach for empiric amoxicillin or ampicillin. E. coli resistance runs 39 to 48%. Duration is 5 to 7 days per ACOG or 4 to 7 days per the Infectious Diseases Society of America, targeted to sensitivities, of course. Let's go over trimester safety. So first trimester, nitro and trimethoprim have mixed anomaly data. Use them if you must, but prefer beta-lactam when you can. Second and third trimester, nitro and sulfonamides are fine first line. At term, meaning 37 to 38 weeks, or even when labor is imminent, stop nitro because of neonatal hemolytic anemia and avoid trimethoprim in the last 8 weeks because of neonatal jaundice and kernicterus. In glucose 6-phosphate dehydrogenase deficiency, no nitro. Avoid fluoroquinolones in pregnancy because of fetal cartilage and tendon concerns. And if you cannot tell cystitis from pyelonephritis, skip nitro and fosfomycin because they do not penetrate kidney tissue. Pyelonephritis is managed inpatient, so admit, hydrate, and start IV antibiotics. Usually ampicillin plus gentamicin or ceftriaxone or cefepime. Keep intravenous therapy going until the patient improves, usually 48 to 72 hours, and 75 to 95% do improve in that window. Then step down to oral to complete a total 14-day course and obtain a urine culture after completion to confirm clearance. If she is not better by 72 hours, think resistance and image the kidneys. Extended spectrum beta lactamase organisms are common, but the 34% figure is a global pooled estimate. North American prevalence is lower. So follow your local antibiogram and involve infectious disease when you see resistance. For a high-risk beta-lactam allergy, the pathway is Astrinum with infectious disease consultation. A low-risk allergy allows a cephalosporin. So let's close the loop. After a recurrence, suppression for the rest of pregnancy is reasonable. Low-dose nitro or cephalexin matched, of course, to the organism. After pyelonephritis, obtain a culture after completing treatment to confirm clearance, then suppress through delivery and until 4 to 6 weeks postpartum with monthly cultures if you suppress. After cystitis, a test of cure culture at 1 to 2 weeks or symptom-based follow-up. After asymptomatic bacteriuria, a test of cure culture is reasonable, though the evidence is thin. Here is a pearl. If group B strep shows up in the urine at any count, it flags heavy colonization. Documented because it commits the patient to intrapartum antibiotic prophylaxis and replaces the 36 to 37 week swap because she's already considered GBS positive. At 100,000 CFUs or higher, treat the UTI and plan prophylaxis. Do not use clindamycin to treat the urine. It does not concentrate there. In penicillin allergy, get clindamycin susceptibility so you can choose the right intrapartum drug. So we have another knowledge check. So same thing. I will go ahead and read. I want you to pause and think through it and let me know your best initial management. All right. A 32-week patient has fever of 38.6 Celsius, right CVA tenderness, and pyuria. What is your best initial assessment? All right, so the answer is C, admit for IV hydration and parenteral antibiotics. So what gave it away? Of course, fever plus CVA tenderness is pyelonephritis. That means admission, IV fluids, and parenteral antibiotics. Nitro and fosfomycin. Nitro and fosfomycin are wrong because they do not penetrate the kidney, and you never withhold antibiotics waiting on a culture in a febrile patient. All right, so here are 6 things that you can carry out the door right now. Screen once with a culture. Treat asymptomatic bacteriuria and cystitis for 5 to 7 days. Targeted and skip empiric aminopenicillin. Nitrites are specific. Leukocyte estrates is sensitive, and both negative rule out infection. Do respect trimester timing. And fever with flank tenderness means admit for IV therapy. And a full 14-day course, then suppress. A GBS bacteriuria at any count mandates intrapartum prophylaxis, documented, and skip the 36 to 37 week culture. All right, here are 7 quick self-check questions. Go ahead and pause the video, try to answer each one, and drop your comment or drop your answers in the comments. The full answer key is in the free study guide linked in the description. Here are all the references, and of course they are in AMA format. The 2023 ACOG Clinical Consensus is the backbone, supported by the Infectious Diseases Society of America 2019 guideline and the USPSTF and Cochrane.